So welcome to our November 1st Journal Club. So we again are on Facebook Live for everybody tuning in. I know there's a couple of hundred people who are probably getting information from Facebook right now to join us, right, Mike?
Mm-hmm.
And we've been getting what, like 700-ish people who are viewing this, and then 200 people who watch us, or something along those lines. We're going to make this a shorter than usual Journal Club because everybody has emergency medicine boards coming up next week. Always pick the longest answer. That's always the one correct. So it's a bit of a stressful time, but I'm sure everybody will do great. And we'll just get started. I sent out a lot of articles. I got enthusiastic while going through the PubMed literature. That happens to me every now and then. So we'll probably just pick 2 articles or so and then save the rest for, I would say, next week, but we are off next week because so everybody can prepare more for their boards. So we're going to skip next week, and then we'll be back again in 2 weeks. And then, Mike, we're posted now on the website?
Yes, posted on the website. It's an edited version. The sound is boosted so you can hear everything better, and so there's some nice background music, so it's a little bit more pleasant viewing.
So I know a bunch of you are watching, and you're certainly welcome to send us your questions now or later, and we will try and answer them in real time as possible. And you're always welcome to join us. So right now we're in Monarch Education, and then we switch, as we all know, we switch the first and third Wednesday of every month. We're in Monarch Education. We're in the small room today, usually in the big room, and the second and fourth Wednesday of every month we're up at Newark Bethesda Medical Center in Newark on D11. We always start at 1 o'clock, and then I guess after boards are over, we'll have the board review from 12 to 1, right, Navin?
Yep.
That's for emergency medicine boards. All right, why don't we get started? So we'll do interesting cases. So who wants to start with interesting cases? Who was on primary?
I was on primary last week.
So interesting pre-hospital cases or interesting cases in the emergency department?
Yeah, so I have a couple of interesting pre-hospital cases. One of them, I guess, was a car accident on Saturday night.
He means collision.
Oh yeah, it was a collision, sorry, a car crash.
Because they're MVCs, not MVAs, because MVA implies randomness.
That's true,
but it's
yeah.
Okay.
So the car crash on Saturday night initially came over as just a regular car crash that BLS was dispatched to. Upon BLS arrival, they noticed that there was possibly one fatality and then multiple patients. The call was then upgraded. Multiple ALS units were sent, and medevac was requested as well. I got there probably about 7 minutes or so after the call was out. When I got on scene, there were already multiple BLS units and as well as some paramedics that were there too. My attention was initially brought to the one patient that was most likely in cardiac arrest, was the driver of one of the cars that probably hit all the other vehicles. He was like slumped over on the steering wheel, not moving. The medics had said that he had a seatbelt tied around, or that was around his neck, which they had cut off, and they thought that maybe there was the potential of getting of a pulse. They weren't 100% sure. At that time, they had asked if we should resuscitate that person, and this guy was also entrapped in the vehicle, and it wasn't really very easy to access him. He was hooked up on the monitor, which showed asystole. We thought about possibly putting a king tube in at that point and trying to just ventilate him through the car window. But it really wasn't able to get compressions. But given that he was in asystole at that time, really not moving, not breathing, an unknown amount of how many other patients there were, we had a couple of people stay there with him to see if they were able to feel any pulse and see if there was any movement. After a couple of minutes, as there wasn't, we pronounced him and then kind of changed our attention to the rest of what was going on. There were actually, in this accident, there were it was all part of one accident, but there was one, the initial one happened probably about a quarter mile down the road, and then there was a head-on collision between the two cars a quarter mile away. So there were 2 scenes going on simultaneously. There were a lot of different agencies involved, multiple different injuries, some leading from just a hand injury to, which we later found out, splenic and liver lacerations. Probably a femur fracture as well, and some closed head injuries. So I mean, given obviously one guy was dead at this. There was a high index of suspicion for injuries of other people. But I think, I think when it comes to these scenes where we have multiple different agencies, the most difficult thing is really figuring out how to control the scene and how to divvy up our resources into what's needed. And that was something I found that was difficult on this, because there's multiple different agencies involved on different radio frequencies, and there's no good way or at least I don't know of a good way, maybe there is one, of communicating between the different agencies and having people, separating the crews into ways that they can go and individually help people. And another thing that I noticed, which is something that's important, is that we're all going in to help at this accident on a 2-lane road, and there's multiple different vehicles, and there's no one kind of keeping control of traffic, and that's something that definitely is important, that kind of needs to happen, and maybe we don't think about from the start, because everyone's thinking about how to get in and help. And when you have a 2-lane road with 20 or so emergency vehicles, you still have to get ambulances out and evacuate patients and everything, so it's something to kind of to keep in mind. So yeah, I think I would love to hear people's ideas or ways of trying to control these scenes, or to make sure the right resources get to the right people. In this case, it was actually 2 separate scenes, which I think makes it even a little bit more difficult as well.
So how many patients total?
So between the 2 accidents, there were 7 or 8 patients.
Did you use triage tags?
So
because initially you didn't know how many people were
right.
patients, right?
So yeah, it was also, so we didn't, so the accidents were in 2 separate places. I actually didn't even know about the other accident until much later on. So I was told after being there for a couple of minutes that there were 4 patients right where I was. We did not use triage tags on them because one of them we pronounced dead, and that was known already. And then the other 3 were basically right all near each other, and each had crews already. So there were so many people there that it wasn't a lack of resources. That wasn't the issue. I think it was more of coordinating the resources and getting the right resources to the right people. There were so many people that wanted to help, which was like amazing there. But it's like when we have so many people, we need certain people to just be in charge of this person and get them out and whatever. And then I think having too many people also presents its own issues as having too few people.
So you needed like a team leader, a branch director, a safety officer,
Yeah.
especially because you're on the accident scene. Yeah, I still would have done triage tags, even if you did it as people were like flown away in the ambulance,
Yeah.
just to say that this is green or this guy's black, and just so somebody definitively knows. But you're right. The more people you have, the more the harder it is to form a leadership structure and get know what everybody's doing. And so too few people on the scene are not good, and too many people on the scene are not good. And people always say, trying to find MCI. Well, MCI is different if you're in the middle of nowhere versus if you're in like an urban area where 7 patients, you don't even need to pull in any extra resources, right? So it really depends where you are and what you have available to you. But everything suffers from communication issues. It's always a problem, and a leadership structure, right? And we always say, who should be in leadership, and first on the scene is pretty reasonable in our state. In most places to form command. It doesn't even have to be an ALS. I think most of your patients were BLS anyway, right?
Yeah.
You can use the EMS physician on scene, which is you as a consultant, to say ALS, BLS, or maybe do things to make, green turn into yellow, or, in your case, blood traumatic arrest being black, for like a quick disposition of patients. And just know who should be triaged first, and then you can go to the green tags and just say, this is a green tag that should go first, this is a green tag that should go second, this is a green tag that should go third. So you're subdividing the green tags. That's what I've always thought the physician's role is on the scene.
Yeah.
But it's difficult because everybody just wants to grab the patient and go instead of triaging them to see, the patient who's 30 seconds down the road really should go before these patients.
Right.
It sounds like it suffered from the same thing we suffer from all the time, the communication leadership structure.
Yeah. I think it's difficult even for me. I don't know which agencies are there, and we don't have the radio communications with them as well. So even that being said, it could have one agency that's just doing their own thing and another agency that's doing their own thing. And even if I'm trying to be central there basically to help triage. It's just getting in touch with that other agency, and maybe we need a representative from each agency who's there together with who's ever in charge of the whole scene
Right.
to help divvy that out.
And a command post, right?
Right.
Like where's your command post? Who, you know, and how is that leader getting identified? You know,
Right.
how is he dressed differently from everybody else? So everybody knows, because
Yeah.
most of these agencies don't know each other. Right.
Right. Yeah.
And that's one solution, to have like, you know, one representative from each, but that's kind of sometimes hard to do practically because everyone
Right.
wants to be involved and not just standing over kind of being an organizational person. One of the other things that I really want to try, and one of these, especially like a scene like this with lots of different agencies and just a lot of difficulty with inter-agency communication, is to try something like the Zello app on the iPhone and just
I'm
help
just
everyone.
being told that the volume is bad, Mike.
Oh, really?
And basically using the iPhone app to say, everyone go on Zello channel, New Jersey disaster. It's something that everyone has a phone. You can easily download it even if you don't have the app. You spread, you know, through, tell everybody else, let's get on this channel, and then on the phone it actually works just like a radio.
Mm-hmm.
It's broadcasting, and you kind of key up. It keeps people from walking on each other. You know, used it in a couple disasters pretty well, Texas, and more so in Texas than Florida. When that was a grassroots thing. But if we have a kind of an organized structure, maybe that's a good, simple solution, just because everyone already
Yeah.
has the equipment with them. And then, you know, until we get these kind of radios but it becomes impossible, right? There's so many channels and so many, and some are encrypted and some are not encrypted, but I think that might be a good solution.
It's difficult when all the organizations work for different, when everybody works for different
Right.
organizations. That's the problem. If everybody works for one organization, life becomes easier because communication is better.
Right.
One
I
of
know
the-
where oh, sorry.
One of the other issues with bringing, you know, one person from each organization, a lot of the paid organizations, they'll only have two people on an ambulance. So you're taking one away, you know, from the potential of patient care and only leaving one
Right.
to work with the patient.
But I guess if you have a paid organization, let's say they're probably on the same channel as a police department. So even having a police officer there,
Not
but
necessarily.
if they're
necessarily,
not.
not
They could be
necessarily.
something completely different as
Yeah.
well.
Yeah.
Yeah, I know in a place where I used to work, the whole county, the county gave out radios basically to every ambulance or to every ambulance that operated within the county, and then in the case of a major disaster, they'd be able to go on one channel basically, and everyone had these radios. There was one radio on each ambulance, or so, a portable radio on each ambulance, and that would kind of, you know, unify everything.
There is in New Jersey too,
Oh yeah.
the GEM system, but it very, very rarely gets used.
Yeah, we have a GEM system in New Jersey, but it's not being used a lot. It could have been used.
And it's-
Also, there's just a lot of ambulances in New Jersey as well.
Yeah.
Yeah. Other calls? How's the audio?
Yeah, it seems to be pretty great actually on our end. So I just put a comment to say, you know, if it's choppy, try to check the internet connection and see, because right now it seems to be streaming perfectly. So
Okay. Other interesting calls?
Yeah, I had another interesting call. Here's EKG. Basically, woman complaining of like weakness, got a history of CHF, hypertension, diabetes. She's on digoxin. The call came in for hypoglycemia. When we got there, she seemed like a little bit off to me. I checked her sugar; it was 125. So I'm like, all right, this is a little weird. I asked the daughter. She said that the sugar was like 55 or so, and gave her something to drink, and then the sugar went up. Even 55 wasn't like too low. Well, maybe for her it could have been hypoglycemic, but either way, at 120, she was still kind of confused. She was complaining of some like visual disturbances and generalized weakness. Her blood pressure was in I don't know, 120, 130 or so. Heart rate was around 75. She didn't have any focal neurological deficits or anything. So this was the EKG that we got on her, which I actually thought was kind of an interesting EKG, because they're just two different copies. And here's a rhythm strip as well. She was kind of moving a lot on
Mike,
the
you
rhythm.
can show people who
Yep.
are.
I got it. It's easier. So I'll show it here, but then I'll put it in later. Looks good. Okay. So as you're talking about it, let me just take a picture and I'll put it into the video itself.
There's no patient information on there.
I'm gonna cut it out. Don't worry. There's no patient info.
So what happens?
So with her, so then I see this EKG and I'm like, it looks like a strange EKG to me. There's flutter waves on there, and then you have QRSs that are wide, and it seems like there's like variable conduction within the QRSs. So I'm not sure if I wasn't sure if this is heart block potentially, but the ventricular rate is going a little bit fast for it to be heart block. So I started, I got a rhythm strip and started marching out the P's and QRSs, and the P's like seemed pretty at the same rate basically, but the QRSs were slightly variable. Then, again, it was mentioned that she was on digoxin, and I remembered vaguely that the digoxin effects of the EKG. And I think this EKG was interesting to me because I think this is one of the digoxin effects basically, that you can get atrial tachycardia or atrial flutter with a variable conduction of the QRSs. And I thought that this is generally more seen in digoxin toxicity, not with regular digoxin use. So I called up the hospital after to talk to the doctor who's taking care of her, because I'm always worried. I mean, I know when, I see when we're in the field and, we notice that someone's on digoxin or some other medication, it doesn't always, looking at the triages or getting the reports on the other end, that information doesn't always get communicated. So I called the doctor to, make sure he knew, and he actually hadn't sent, I don't think he knew that that she was on digoxin, or maybe he knew and didn't send, but he said he hadn't sent the level yet, so he was going to add it on. Either way, it came back as normal, which I was kind of surprised about. I couldn't really find anything else that was explaining her symptoms. She had visual symptoms. She didn't really have any weakness or anything like that. Any appreciable focal weakness. So I'm like, oh, this is gonna be awesome. This is gonna be digoxin toxicity. But then the level came back at 0.8. So it wasn't that. They ended up admitting her for CHF. I don't really think that explains it either. But I don't really know what was going on.
You can certainly be dig toxic with normal dig level. Right? So you don't have to have a normal dig level to be dig toxic, and when it used to be an old pimp question, what's the only rhythm dig can't induce, and the answer used to be AFib, but we showed that dig can actually cause AFib, even though we give dig for AFib.
Yeah.
It could be. I mean, it's still. I mean, visual changes.
Yeah.
And this could, but 0.8 is not a high level at all.
Yeah. But yeah, I thought the EKG, because the axis was strange on that EKG, the whole rhythm, everything looked kind of weird. I don't see EKGs like that.
But if she was bradycardic and her heart rate was 40, you still would have given calcium, right?
Yeah, so calcium is because it blocks it changes the calcium potassium pump, and in these cases, you want to give calcium. And then the chronic dish people who may be hypokalemic, her labs were actually all fine in the end. But with ditch toxicity as well, you can get hyperkalemic.
Right. And it's a myth in medicine that you can't give calcium to people who are ditch toxic, right?
Yeah.
So because we are big believers, if you're bradycardic from any reason acutely, we just throw calcium chloride at you over the console pre-hospitally, right? And we give just a gram of calcium chloride, which we have back again, right?
For now.
For now. And then we'll run out of it again next week. So that's interesting. What else?
I had another hypoglycemic lady who had a sugar of 23 who was just talking normally and had a better memory than I do. She remembered my name and everything that was going on. I'm like, wow, this is incredible. I was pretty impressed that she was functioning so well at a level of 23.
So we're switching over now, right, from D50 to D10 infusions, because we know from the Moore paper, which was like 2015, that you do not need to give D50, even though the whole world is giving D50. You do not need to do it. You don't need to do it. It prolongs your hospital stay by 24 hours. It's a complete myth of medicine. So we're following what many other people around the world have done, and we're going to do D10 infusions, right? And then we just obviously recheck the blood sugar. So I believe nobody in medicine needs to get D50 ever in the hospital or in a pre-hospital setting. Have we started that yet?
The memo just went out this week, so
Okay.
the first bags of D10 went out. It's storing orders this week.
And if somebody's hyperglycemic and you give dextrose, remember you have to have complex carbs after that, or they'll get hypoglycemic again. And so if I give D50 or some dextrose-containing solution and somebody has persistent hypoglycemia, I give it dextrose again, and then if the hypoglycemia persists, then I think, what am I doing wrong? And I always think about, what do I think about? So persistent hypoglycemia with dextrose not working diagnosis.
Insulinoma.
All right, maybe. What else?
Sulfonylureas.
All right, what else? Beta blocker, all right. Pure beta blocker overdoses are uncommon. But,
very.
adrenal insufficiency, right? So hypoglycemia, not responding to dextrose. Maybe you throw in some hypotension. Maybe you throw in some hypothermia. Maybe you throw in some nauseous and vomiting. Maybe you throw in some abdominal pain. It's all board stuff. And that's all adrenal insufficiency. So I always think of adrenal insufficiency with somebody not responding to glucose who's hypoglycemic. All right, any other interesting calls pre-hospital or in the ER?
I have a call I got a question on. It was one from yesterday. We had a 43-year-old guy, woke up 5 o'clock in the morning, crushing chest pain. When the unit got there, massive inferior wall and 8-10 millimeter elevations. Looks like an underlying third-degree block along with it. So they tried pacing him, gave him 100 of fentanyl, didn't do anything for the pain of the pacing and like that. So they were asking for ketamine because they wanted to disassociate him. And just curious about feelings on giving ketamine to disassociated patients having a STEMI.
So he was having a STEMI. They gave 200 total of fentanyl?
I believe so.
And that did nothing?
No.
You know, yeah, I mean, my first thought is sure, why not? My second thought is, well, he has to sign, you know, he'll have to sign consent to go to the cath lab and he'll be disassociated. It wouldn't be the first thing I would pick. I don't know that they did anything terrible, except, again, you want somebody to be pretty alert and oriented ×3 when you're taking them to the cath lab to sign that consent. And that consent will get signed hopefully really, really quickly when they hit the ER, if not going right through the cath lab. I probably would have kept trying fentanyl in that patient. Maybe 200 for that patient just wasn't enough. Maybe they needed 300 plus. That's the only downside.
Yeah, and that's why I was curious with it. I mean, there's clear cut that this is a STEMI. There's no question about it. And to give him ketamine and get him disassociated, is that going to delay him going to the lab? Or are they going to do implied consent?
You know, the only other thing is if when he hits the ER door, somebody's going to say, we see this all the time, well, he's altered now, should we CAT scan his head, even though we know it's from the ketamine? And although that's not needed, we know that's the reality of life, right, that people will do that. And I do need STEMIs to sign consent, right? I don't know, what do you guys think? It wouldn't have been my first choice.
I wouldn't be my first choice either. I think making sure you get the whole story and the true story is important. Okay, it's STEMI, but there may be more to the story. Maybe he was having this tearing back pain and is hypertensive, and this is like a dissection now, dissecting into the coronaries. That would be important to know. I'm sure, I guess they could still see that in the cath lab and work through that, and they tend to look, but I don't know. I just think there may be better ways.
Have you guys ever had a STEMI you couldn't make a dent in their pain?
No.
I recently had a similar case. It was like a Wellens. I think we talked about it actually on Journal Club. Sorry, I'm just moving the camera so we can get everybody in the shot. But it was like a Wellens, and the guy really was refractory to fentanyl working as for pain control. And ultimately, I think he ended up being, you know, a substance abuser or something like that, so he had a really high tolerance. But I think we did what you just said. You know, you just kept throwing fentanyl at him to get his pain controlled, and then he went to the cath lab, so I don't know what happened. Of course,
so you had a Wellens on 12 leads, you had a proximal LAD lesion that was just having a lot of chest pain?
Yeah,
but
it was
wasn't
symptomatic.
actually...
It was really strange. I think we talked about this a couple weeks, was it 3 weeks ago or something?
Yeah. How much fentanyl did you give?
I think we gave him to 400, probably 400 or 500 of fentanyl in total, because I kept giving 100 micrograms, and he was getting delayed going to the cath lab and just screaming in pain, holding his chest, so we just kept giving it to him.
You know, I mean, you think about what causes that severe chest pain, and I mean, I think of things like severe crazy chest pain. I think of dissection. I think of mediastinitis, and besides that, I mean, and then STEMI. But besides that, I think those are the three things which I've always learned, which are the things that cause the terrible. I mean, certainly I guess you can have like a Borhoff syndrome and something esophageal, but that can cause severe pain.
It was strange that he was in so much pain with that Wellens morphology. Ultimately, he did start throwing ST elevations once they got to the cath lab, and they got him on the monitor. I don't know, of course, this is all going to change in the future when we start doing pre-hospital heart caths, just not the ambulance.
So he had a type A Wellens, and he had a confirmed proximal ID lesion in the cath?
Yes, 100%.
100%. So you saved his life.
Yes.
So somebody recognized Wellens
It was,
before they
it was
saw a
me.
STEMI on the EKG.
That was one of our attendings who was on his way out the door, was handed the EKG, and then he walked over to me and said, he needs to go to the cath lab. And then I said, okay. So
and then the guy went home?
So I don't know. I think he went. I think he went to telly after. Not
No, I meant the attending.
Yeah.
Yeah.
It's leaving out.
So he saved the guy's life technically. I don't know. I probably would have called cardiology fellow at the very least if I saw that morphology, but I don't know. I'm sure I would have if I saw the patient off the bat. Would have called it STEMI.
So.
I think there's also something to be said for seeing the patient when they come into ER, and I mean, as ER guys, we're used to seeing people like that, or potentially under the influence of ketamine. When we call on other services, stuff gets very muddied for them, and like you were saying, I think there's a lot more hesitation to do things when people are altered or whatever. And I think there's something to be said for knowing if this guy's STEMI is getting worse or he's progressing, we may not know about that if ketamine was given to him, basically. Whereas if we're just watching him and kind of seeing what goes on, it could be subtle things that we're, seeing before the change of the vital signs that may make us more concerned or less, or more concerned about him, really.
So Rich Zaleski is asking, is chest pain associated with Wellens all the time or normally? And I think my answer to that is no. Usually
No.
Wellens people come in, their chest pain is resolved.
Right.
Classically, they don't.
That's
have
why
any
it's an
pain.
unusual case.
Yeah. And then usually, if their dynamic changes, they start getting chest pain, and then they start having elevations on the EKG if you catch it. So
Yeah.
the answer to that, I think, is no.
So what happened?
That's my next meeting. I'll find out when I go to that meeting today.
The other thing, by the way, is I'm a big believer in giving some people a touch of benzos who are like anxious with their anything, with their burn, with their chest pain, with their STEMI. Giving them a little Ativan with their narcotic is totally fine.
And Anna Ryan is asking if we can have informed consent pre-hospitally. So we have a general consent to treat that we signed with the ALS chart. Is there any way to expand that to the receiving hospital so they can just have consent to definitive treatment?
I mean, the tradition in medicine for almost every procedure is the person who's doing the procedure is getting the consent form. So the truth is, in the emergency department, if you're going to the OR, we generally, it's a generalization, don't get consent. We like the person who's doing the procedure to get the consent if you're going for an operation. With that said, sometimes we do people favors and we get consent for them, but generally on the consent form you have to list all the complications and you're held responsible for all those complications. So that's why it's just safe for the person who's doing the procedure. So we're not even doing it in the emergency department. And listen, you can get wheeled through the ER and get consent in the cath lab, right? So getting that consent form doesn't really, it's a 2-second form, right? You're just asking somebody to sign the form, and you are listing all the complications. And sometimes those complications can change depending upon how you're presenting. So I don't know that it would save time, and I do think it might change your risk a little bit.
This is one of the concerns when we started to do the ED pauses and bypasses on STEMIs, as far as who's going to do the consent. And that some of the ER physicians were not comfortable doing the consent for a patient having a cath.
Well, they don't want to assume the liability.
Yeah,
the truth is, I can consent anybody for anything. We consent people for dialysis. We consent people for a variety of things. I don't know. Do you guys consent people for surgical procedures, or somebody's no? Does anybody?
We don't know all the risks and
Right, not
downstream
unless
stuff.
I'm doing the procedure. The only thing I consent for is hemodialysis if they're already receiving dialysis, because they, in theory, have already been consented multiple times. They know the risks and benefits. So this will delay their care if I wait for the renal doc to come in, the nephrologist to come in and to consent them. So,
Because it may, right, because your argument is if they're getting dialysis in the middle of the night, typically the nephrologist isn't coming in the middle of the night in most programs in the country, so it's either you as the attending or nobody.
Right.
One way that other hospitals I've worked at before got around this a little bit is they had their cardiology department come up with like a standard unified consent, and it listed all, it's a cath, here's the risk, here's the benefits, because they're pretty standard risks and benefits. And it was just a pre-printed, pre-filled out form, and then we could get that form and get it ready, and literally it was just a signature, and then the
Right.
cardiologist could say any other questions.
And we know for a STEMI, it takes you longer to hook them up to a portable monitor than to do the consent form. I mean, we're talking about seconds, right?
Yeah.
So.
Seconds.
Yeah, generally for consents, my rule is if you don't know how to do the procedure, you shouldn't be consented. But in the case where you have everything already pre-printed with all the different risks and all the different benefits, I mean, it would be reasonable. But like I won't consent people for initial dialysis because I don't do that. But if they've been on dialysis, like he was saying, I do those. I do blood consent because I transfuse blood, things like that.
Right.
Yeah, I've been at facilities where the nurses do the consent, and the physician comes down and just signs the piece of paper.
Right.
So, and I mean, there's an order in the computer entry system for nurse to get nursing order consent for, and you just put the name of the procedure, and that's
Right.
it.
But the
So
physician's still signing.
the
form.
physician signs it, but a lot of times, and right or wrong, but they will sign it as they're walking into the holding bay to say hello to the patient so they can go scrub in.
Right.
So again, I mean, I think there was just legislation passed in Pennsylvania, I believe, where physicians have to be the ones getting consent. You can't delegate the consent anymore. It has to be the performing physician.
Right.
NPs, PAs can't do it anymore. It has to be the physician. So, but I mean, I agree. I think the department, if everyone in the entire department has agreed on a particular consent and standardized a consent form for a common procedure, I mean, I don't think that's a terrible idea.
So, okay, great. Let's go right into the articles. So I do want to stay on time. Anybody have any preference which one? Since we'll probably only do two.
I like the,
I mean, they were all great articles this week.
yeah,
you
they
know?
were. I like I read the laryngeal tube versus face mask. I thought that was something interesting that's coming up a lot. Here, let me.
All right, so this is the EMT-led laryngeal tube versus face mask during CPR multi-center prospective randomized trial in the Scandinavian Journal of Trauma. Anybody get this journal besides me? Anybody get this at home? No?
I've quoted it before.
You've quoted it before?
I get it because of you.
Thank you. So this is Anna Fiala, and she did this in what month? 2017.
Yeah, so I'm just putting a picture of the article right here in the video feed so they can follow along.
And this is open access, which means anybody can get this article.
Yes, yes. All right, and then I'm just putting myself in there too because I feel bad, having everybody else on webcam but not me.
Do you need the microphone closer?
No, it's good. I think the microphone's actually doing a good job of picking everything up. So, all right. So this is basically EMT-led laryngeal tube, as you said, versus face mask. And I think it's safe to say the laryngeal tube that I'm most familiar with, and probably y'all, would be the King tube or some equivalent. And that's just a device that has a big bubble basically that stabilizes the tube in the pharynx, so it effectively delivers air to the trachea regardless of the position in the pharynx most of the time if it's inserted appropriately, right? So they were basically taking this laryngeal tube and in out-of-hospital cardiac arrest and comparing that to the BVM. So currently I think this laryngeal tube is a subject of debate. It comes up a lot in the literature and social media about whether or not we should be using it as a first-line airway in cardiac arrest, and not only that, I mean pre-hospitally too. So I think we might have reviewed articles that they're using as a first line in cardiac arrest pre-hospitally, right? ALS protocols, because that sounds familiar. But anyway, it's some people it's kind of split 50-50. Some people feel don't waste time getting an ET tube, don't waste time with BVM ventilation because it's the bag of death. You're filling up their stomach, you're reducing venous return and you're increasing intrathoracic pressure, reducing their cerebral perfusion, doing all these bad things. So a lot of people said just do this this quick insertion of the LT tube. And the other side of it would be patients who have contraindications to BVM, like beard, like Alex over there, or I'm just saying, you're not a contraindication to BVM, or Bob, or patients who just have some, they're obese or they have something that's preventing them from BVMing effectively. So that's kind of the other side of the argument that we should maybe be
So
doing.
like blood, a bad lemon score, just
Bad lemon
realizing
score.
like a difficult airway.
Yeah. So this was basically an open, prospective, randomized, multi-center study, really great design, and this was out of Austria, I believe, right? Yes, Austria. Where in Austria, the King tube, or the LT tube, the laryngotracheal tube, has been approved for pre-hospital use by BLS, by EMTs. And this didn't really distinguish whether it was ALS or BLS responding first. I'm not entirely familiar with their system, so I don't know if they're paramedics, everybody who's responding in the field, or if they're BLS skills. But anyway, they said all their EMTs are responding to cardiac arrest. And it looked like, I did a little research, it looked like they primarily have emergency physicians responding to all their high acuity patients. So EM physicians are responding out in the field to these cardiac arrests, and they might beat the BLS there, or the EMTs there, and they might arrive afterwards. So ultimately, they required that all of the medics who were using this tube pre-hospitally got training. So they did a 2-hour training course for the LT insertion, and inclusion criteria was out of hospital cardiac arrest in patients greater than 18, and also they excluded patients where they couldn't get. I didn't really understand their consenting process, but where the consent process was hindered either retrospectively or at the time of the scene, or for some reason the EMTs the physician beat them to the scene, so the physician initiated a more advanced airway, so those people were excluded, and then a few others, I think I said anything less than 18. And then if there were 2 failed attempts by any modality, they were automatically excluded. So, I don't know if this is similar to our patient population, or it's not really similar to the fashion that we respond out in the field. But they got a pretty good look, and if you look at table 1, that's basically where they compare the pre-study training, basically the LT group to the BVM group. They rated it, paramedics or the EMTs rated it based on ease and then efficacy. So they thought that ease of handling, there's really no statistical significance in how easy it was to do the BVM versus the King tube or the LT tube. Efficacy, however, they thought it was a lot, there's increased efficacy for just taking the tube and having the ability to bag quickly and efficiently. So in the survey that they used, the LT tube won in that regard. So let's see, let me just scroll down to the next table, table 2. If you look at patient characteristics for all the patients, and there were 35 in the LT group and BVM group only had 41, so low N, but they were randomized appropriately. And there's really no statistical significance if you look down the p-value between each group that I could tell by looking through. So they're pretty similar to begin with, so that's always something important we're looking for. And ultimately, long story short is, so pre-training or pre-study, they found that it was more efficacious, but in the pragmatic scene, in the clinical scenario, when they have a patient in front of them, there was really no increased efficacy or no increased ease of handling the device. So it didn't make it any easier for the EMTs out in the field. What about, so that's primarily what they were looking at, but they did comment on certain like ventilation safety and then outcomes and everything like that, and it really, there was no increased outcome or anything like that for them. So I don't know, you could kind of correlate this to say maybe the LT tube really is not a good first line for cardiac arrest, but you kind of have to look at who's going to be using it. I think for this study, if there are EMTs, if they're BLS trained, maybe it's not equivalent to our system where the ALS is going to be establishing the airway. So they might be a little bit more familiar with the airway to begin with. But I think I'm a big fan of the device myself. I think it's a great device to kind of secure, quote unquote, an airway better than a BVM, and not as good as an ET tube, so it's somewhere in the middle. And there have been many studies already showing there really aren't many adverse outcomes, except in animal models, though the only ones that I'm familiar with. In animal models, apparently when they were using the king tube, if they inflated it or overinflated it, it was compressing the carotid arteries and decreasing perfusion to the brain. But as far as I know, they have not demonstrated that in human studies, right? So my thinking right now is, why not? It's more secure than a BVM. You don't have to have somebody sit there and do the C&E and hold it in place and try to get a perfect seal with every bag. And in fact, you're probably inflating their stomach anyway with a BVM, so why use it? So I don't know. What do you guys think?
A couple of thoughts in my head. One is, I hate when people say, like, for naloxone, for heroin overdoses, you don't need to give naloxone. You just need to bag them, right? That is an incredibly non-EMS physician way of thinking about things, right? Because for all the people who say that, go in the back of a moving ambulance and try keeping a BVM on somebody's face, right? It will not work in the back of a moving ambulance. Now, the article is kind of interesting. If we look at the history of this, we've had swings of thoughts about whether you should be intubating pre-hospitally, whether you shouldn't. And for a while, we had a lot of data to say paramedics should not be intubating patients, right? That's what the science said. And then we've had some more recent studies to say that they should be intubating. And the studies, we had a big Japanese study, we've looked at several papers in the last 2 or 3 years, which said a benefit to intubation over just a BVM. I think it's where the science is now. But if you look at many of the Iraq collecting hospitals, they still don't allow ALS to intubate in the first 6 minutes of arrival, right? With the focus on cardiac arrest patients, at least doing a good CPR or circulation airway breathing, and not focusing on the airway. Now, Navin sent me an article, what was it, yesterday? So hot off the press, I don't know if this is even published yet, but this is from a French study which was just presented 2 days ago at the European Society of Cardiology, and it's not out yet, but they're reporting it, where this French author compared BVMs versus endotracheal tubes. And he kind of says in this article that his whole way of thinking was to totally get rid of endotracheal tubes in France because BVMs are much more supported in literature. So he did this study, and apparently it's multi-center. Again, I just have the review of the paper, not the actual paper itself. But he actually found the opposite of what he thought. Endotracheal tubes won out over BVMs on every freaking parameter. In fact, for the aspiration parameter, you were twice as likely to aspirate if you used a BVM instead of the endotracheal tube. And they had a lot more BVM failures and I'm not sure how they defined a BVM failure, it doesn't say here, versus endotracheal tube failure, where their failure rate was 2.5% versus 6.3%. But again, you were twice as likely to aspirate. So in France, they basically concluded that they're now not going to go with the BVM first and endotracheal tube second because of this study. We'll see. Hopefully, I can find it online in the next couple of days. I know we'll talk about it in the next 2 weeks. So that's good. I mean, we're big proponents of paramedics intubating, and I still think that that's what's winning out now in the literature, although I acknowledge in the past several years it wasn't winning out. I don't know. I think BVM is a skill. I think even if you do it perfectly, you still can fail doing it. And I think in a moving in a moving ambulance, doing good BVM skills is very difficult. And even if you do it perfectly, a tight seal with a difficult airway, with a bad lemon score, with a big beard, is incredibly challenging. And that's why I like the idea of intubating patients at the right time, right? Because we still talk about in a cardiac arrest, probably a king tube or an LMA or whatever you have, or IGEL is the right thing to do, and not screwing around with the airway for somebody in cardiac arrest. But I like the idea of BLS using king tubes.
Yeah,
properly train people.
Yeah.
Just train people properly and let them put in LMAs. And I don't think the concept of carotid pressure, although I acknowledge it's out there, is really going to pan out.
Yeah. Yeah, I think, that'd be pretty amazing if you already show up to a scene as a paramedic and the patient already has a reasonably secured airway. Obviously it's not as good as an ET tube, but that kind of takes one thing mentally out of the equation if it's already established and they have good breath sounds bilaterally with bagging. The other thing they mentioned, they didn't really make any correlations between mode of ventilation and things like survival to discharge or patient-oriented outcomes. So, that's really that's why you can't really take this study and apply it to your clinical practice, right? Because there's no patient-oriented outcomes that they commented on. So, if you can prove that there's worsening mortality or no survival benefit or anything like that, sure, maybe I'll consider it. But while this was pragmatic and I thought pretty well designed, it really lacks those outcomes that you want to see. So who cares about ease of use if the patients are
So the harder question is if BLS puts in a King tube or LMA or iGel, and you get there as an ALS provider, do you take it out to intubate or do you just leave it alone? What do you guys think?
I think if it's effectively ventilating, I'd leave it alone.
Keep it until you get ROSC.
Keep it until you get ROSC. And when you get ROSC,
A sustained ROSC.
sustained ROSC. Define sustained ROSC?
More than 5 minutes.
More than 5 minutes. So
do you want to wait on scene then for 5 minutes before you start bringing the patient to potentially intubate them?
That gives you time to move to the ambulance, so you have sustained ROSC. You can package the patient,
So if
move to the ambulance, and then either re-intubate them in the ambulance, or if the airway is still very secure, the patient's oxygenated, I would just leave it in place.
Yeah.
yeah.
Don't try to intubate in the field. If the King tube's working or the LT tube, we keep saying King tube.
But my other concern is by doing that, you're also having degradation of skills. Because we intubate a lot for cardiac arrest as well as respiratory distress.
And that's always been the concern about not intubating cardiac arrest.
Right.
Because if you just go straight supraglottic of some sort, you're going to lose that skill. And then when you really need it and the patient needs to be RSI'd, do you have the skill to be able to do that? Especially when you're only intubating. Our full-timers really don't have too much of an issue because they're intubating 10, 12 times a year anyway. But it's your per diems that are only intubating 1 time a year. And it's mostly in a cardiac arrest situation.
And now those per diems may be intubating with video laryngoscopy, or they may lose an intubation, like you said, to an alternate airway.
Yeah. So, your skills degradation is a huge issue when you're only using supraglottics.
Right. It's a hard question. There's no right answer for that.
When they come into the ER and I'm receiving an active code in progress, that I just leave the King tube, especially if I have good ventilations, until I get ROSC. So I'm not going to waste time unless we're running it for a good 10 minutes. I'm like, okay, well, let's just try to secure the airway and make sure that's not.
So we're training a generation of doctors who can't put in central lines without ultrasound machines. We're training a generation of doctors who probably aren't doing too much direct laryngoscopy anymore. They're doing video.
Nasal intubations too?
With nasal intubations, we're not training anybody. That may be okay though in most aspects. But we're losing a lot of, and if you look at people who trained 20, 30 years ago, they did a bunch of surgical Craigs. Everybody with head trauma got a surgical Craig, and more than 20, 30 years ago, but isn't that okay? We get smarter in the literature, and so we do things differently.
Yeah, we get better. You use technology as long as it doesn't rely on batteries too much, because that's my other concern is what happens when you go for your video laryngoscope and the batteries are dead. So you go in, you can't see. Now you have to your fallback is direct, which you're not used to. I feel like you should be proficient in both. I'm just curious. Have you guys ever put in ultrasound? Put in a central line without ultrasound?
Yeah.
Yes.
Yeah. And because the ultrasound machine was broken, or what was the?
Usually the crashing patients, and it's just a quick.
Crashing patient.
I don't think I've done any IJs without ultrasound.
I've only done 1 or 2, and it's just because the cardiology fellow was old-fashioned, I guess, and he said, "Why are you getting the ultrasound? This is how we."
So those cardiology guys are going away, though, right? Yeah. Everybody, the whole generation now is using ultrasound. But it's like okay, though, isn't it?
So
the problem is when you get done with residency, and you go to an ER which has no ultrasound machine. I know there are less of those around nowadays, but they still exist.
Yeah. I'd say I'm more comfortable doing a subclavian without ultrasound than I am because you have more anatomical landmarks, you know, and every patient's different, so you can't always rely on your triangle, the anterior triangle, to say, okay, the IJ is definitely below this, and everybody has comorbidities, so they have stents, they have clots, they have thrombus, they have everything like that. So if I'm not getting flash on the first try, I'd be concerned that I'm getting close to big red. I don't know.
So I teach our residents to aim and think about where they're going to put it blindly before they use the ultrasound, and that's kind of like the best way to do it, I think.
Yeah.
Is where would you go?
Put
if
your
you
finger
didn't have
where you're
this
gonna go, and then put the ultrasound on and see if you were right. I like to do.
Right.
And
I just
sometimes it's
remember, like, you know,
drastically
feeling
wrong.
that lateral border of the SCM and pushing away from the carotid, and you just go, do people do this anymore?
Having them turn their head in a certain way to.
Right. All right. Any other thoughts about this article? Did it change anybody's practice?
No, I mean, I think it's also like the things we also need to look at. If you're still squeezing the bag a lot, it doesn't matter if you have a BVM or a tube, and you know, if we're dealing with pressures and stuff like that. And if breathing isn't so helpful in cardiac arrest, it doesn't matter what we're using as well. So maybe from the start, yeah.
So with any
compressions, yeah.
with
So
any
I don't know what the answer is.
Yeah,
in this
with
case.
any article that we're reviewing, you want to make sure that the population, first of all, the patient population is similar to the patients that you see, but also in this article they were talking about the EMTs. I wasn't sure from the article if they were BLS or ALS.
Yeah, I don't think they specified.
Looking online right now, they're saying that they have 2 levels of EMTs, one 260 hours, and they're considered basic life support. They have
This is Australia,
ALS,
right?
Yeah. Well, Austria.
Austria.
Austria, right.
Yeah.
Can't
For
Little
ALS,
mistake.
they have 480 hours of additional hours on top of that, and they can work in ambulances that support the physician or work independently as well. And then they also have non-emergent transports, which are just attendants with no training, really, just basic training on the job.
We need some of those.
I wonder if it's got to be similar to Germany's system, where I mean, Germany has a
Well,
large.
the Franco-German model is just more physician-based, and it's just
Yeah.
how the EMS system developed.
So, I mean, you want to transition into the CCCPR paper in children?
Yeah, that was.
What a mess this is.
Yeah, what a mess. This is a good.
I mean, I thought I freaking understood this. So I think, to my recollection, we had like 4 studies I've read on CCCPR, which is basically compression-only CPR, which is basically yes, going into malls and teaching people. You just find somebody on the ground and they're in cardiac arrest. You just start doing compressions. Don't worry about the airway so much, right? And there are 4 pretty good papers on this, and this is just like the nickel paper. We all thought PIC through CPR was the right thing to do. Then the nickel paper, which I think was in 2015, and I think JAMA said, hold on, PIC through CPR may not be the right thing to do. All right, go ahead.
Yeah, so this was a Japanese study. It's a pretty large database. The Japanese are really, really good about their like large pooled databases. They looked at 6,810 kids, all less than 18, using their, I think it's a national registry. They looked for 7 years, from 2007 to 2014, and they basically also had a good outcome. Their outcome was measuring 30-day neurologically intact survival, so basically functional and the point, right, of CPR. And then they looked at the 2 different styles: compression, chest compression only CPR versus conventional CPR, which is respirations. And all of these children were all out of hospital cardiac arrests. And then essentially what they were seeing, the propensity score matched the kids to try to make them equal cohorts. And they got a total in of 2,682 kids from age 1 to 17. And basically the summary is their overall neurologically intact survival rate was significantly higher in conventional CPR than in chest compression only CPR. So 9% survival in conventional CPR, 9.4, versus 6% in chest compression only CPR with a P of 0.001. So statistically significant and pretty large numbers. However, there was no difference when they looked at people that with known cardiac etiology. They don't really specify exactly how they knew that, whether it was they had known congenital conditions or known heart conditions and went into cardiac arrest, and people with known cardiac conditions and a presumed cardiac cause, either by initial shockable rhythm or by having the known history, there was no difference in whether you used chest compression only CPR versus regular CPR. And then they also looked at subgroups, and based on both age, so they looked at infants to 1 year old, 1 to I believe it was 8, and then the whole cohort of 1 to 17, and essentially conventional CPR was better in all of them, unless you had a known cardiac cause or you had an initial shockable rhythm. So yeah, that it makes it kind of a mess, and I wonder if it's partially, well, number one, the CPR in Japan is a little bit different, and they mentioned that in the discussion paper. For instance, they don't really use epinephrine, especially up front. Only 5% of these kids got epinephrine, which would be way different than our U.S. system. Right? Typically, we would use epinephrine in most of the cases. They cite 65% in the U.S. system, but that's one difference. And I wonder if the other kind of difference of why they see some of these changes is because they're kids, right? So certainly in cardiac causes, there's no real difference. But presumably a lot of pediatric cardiac arrest is not from STEMIs, is not from heart attacks. It's from other causes. Right, rather respiratory or infectious or septic or traumatic. And that may be able to explain some of it, but why that respiratory component is so important. But you wouldn't think it would affect survival that much. Basically a 3% change in survival is a pretty big number. I would have expected to be maybe closer. And then, I think that's the key point.
So, where does this leave us? So do we tell people to do a CCCPR for adults only and not children? So if a child drops in the mall, you ventilate, and if an adult drops in the mall, you don't ventilate? Rob, you teach this for a living. What do you think? Talk to the camera, Rob.
I don't know where it leaves us. I agree with you. It's a hard one.
Are you doing these classes for lay people, like in the malls and stuff?
We're not doing like hands-only type of stuff. We're doing some in the community, but not like that.
Now, I think it's important to mention this is all EMS-based resuscitation.
Yeah, it's not
so this
general.
I think that is different than a general community layperson, like either dispatch-operated CPR or trained. Then I think that it
maybe.
probably number one, they have no equipment, and
That's probably okay.
and it's probably is the right thing, because that gives you more time to get to that shockable rhythm. But
I don't know what you're saying is true, but it could be, right?
Right.
It could be. All right, I'll give you that. I don't know. I mean, maybe. Listen, we know apneic oxygenation is the right thing to do, right? We reviewed this last year, but yet, I mean, Mike, you'll have to admit that not all the apneic oxygenation studies are supportive of it, right? And we try and figure out why not all of them are supportive, and maybe, like the fellow study, maybe that wasn't supportive because the people were oxygenated to start with.
Mm-hmm.
So maybe it's the same thing, that when you're oxygenated okay to start with, you don't need that apneic oxygenation. You don't need the extra oxygen, and that's why it wins. And so you separate out who goes in front of you versus who doesn't go in front of you, and you treat them differently. Does that help to explain this? I mean, but if you come across somebody in the mall, what's the chance they're going to come in front of you?
right.
Right? Or what's the chance you're really going to know their downtime? So he just dropped it. Did he really just drop 5 minutes ago or 2 seconds ago? How fast do you get to somebody? I don't know. I mean, I definitely think this tells me again, just like the nickel paper, there's some people who you need to oxygenate. You can't just do continuous compressions, right? And to interrupt compressions in some populations is absolutely needed. So PICR CPR isn't the answer for every single person, right? But I mean, maybe for a lot of adults, and maybe for unwitnessed arrests, but maybe witnessed are totally different. I mean, Bob, we always talk about that. You probably should shock at different amounts if you're a witnessed arrest versus if you're unwitnessed arrest for VFib. Right? You probably don't need to start at a higher number of joules if you're a witnessed arrest. Because the idea is to convert somebody with a minimum number of joules needed. It's difficult to figure that out. So, any thoughts about this?
I feel for me to change my practice or anything, I think the focus should still be compressions as we've changed it, you know, and to ignore the airway altogether, I think is a little foolish,
But the nickel paper was the best statistical paper we've ever had on compression only CPR. So
what was that population? Was that all U.S. based or was that?
it was a multi-center trial, so I don't remember if it was all U.S. based or not. But it was in a good journal, the best statistics. It certainly had some flaws, but we're relying on PICR CPR is based upon observational epidemiologic evidence. This was based upon a randomized controlled trial. It doesn't mean it's right. It just means we shouldn't throw out the best paper ever done, right? And this paper was pretty good too. There's got to be a point where we just go, I don't know what this means, but it probably means some people need some ventilation.
Or a little.
Well, and you're grouping all cause of cardiac arrest as one entity. But if you know that this person is sick, they've been having fever, they've been coughing up junk, they have pneumonia, and they went into a hypoxic arrest because they can't breathe, you treat them differently. But you may not.
Did they do better because they had epi, or did they, did they not do better because?
Well, I
they
think
had
that's
epi?
an interesting question, right?
Right. I mean, we've discussed that epi. The summary of all the epinephrine literature is you get more ROSC and more people don't walk out of the hospital alive. That's a summary of all the papers, and both papers have deviated from that. And we all talk about giving beta blockers in VFib arrest instead of giving epinephrine in VFib cardiac arrest. I don't know. I mean, if I remember right, some papers reviewed last year from Japan, they have 3 providers on every Japanese ambulance. I don't know if that's still the case in Tokyo. I don't know if that's still the case or not. That's different from us, certainly. I don't know. But again, maybe this is just kids are different. So because kids have more hypoxic cardiac arrest, maybe that's why you really need to ventilate them. So if that's the case, Rob, maybe we do teach people when you come across a kid, don't ventilate. Because we teach them that these are usually not from cardiac causes, they're from respiratory causes, and then we're saying, but don't ventilate.
Healthcare provider level? Absolutely.
But not bystander.
People are hesitant on that. So.
Because you're more focused on the bystander getting the compressions right.
Correct. And they're more likely to do ventilation as well.
Right. Although I guess the argument is, are wrong ventilations better than no ventilations?
They're more likely to do it ineffectively.
Right. Everybody agrees?
I think simplifying it for bystanders is key. It's already stressful enough, and you're already confused enough. Adding pieces just makes it worse.
All right, it's 12:15. How about we do one more? Anybody pick one, and I'll let you guys go home and study.
The early angiography or the ventilation.
You want to do the early angiography?
I don't know. Whatever.
Yeah.
Sure.
That's a good one.
Will you be good? Okay with volume, Mike?
Yeah, just project towards the microphone. Actually, I think is picking pretty much everything up nicely. This room's very
Okay.
acoustically.
So in resuscitation journal, did early coronary angiography in patients resuscitated from out of hospital cardiac arrest without ST segment elevation. So this was a meta-analysis from inception of the databases which they looked at, which was a number of them, up until February of this year. It was to determine the impact of early versus delayed versus no coronary angiography in patients without ST segment elevation.
And this is important, by the way, because we talk about this all the freaking time. Like in almost every journal club, we talk about this. Every EMS provider, this is basically, listen, it's easy. If you're having a STEMI, we bring you to the cath lab right away. But what if you have a cardiac arrest and you get ROS and you get a 12-lead EKG and there's no STEMI? Should those patients be brought right to the cath lab? And that's always the question we have.
Yeah, so like Dr. Morello said, there is this sub-pocket of patients. So when they get to the emergency department, we get the EKG, there's a STEMI, they go straight to the cath lab. That's a class 1A indication. And then there's these patients that don't have a STEMI on EKG, but they're hemodynamically or electrically unstable. And then there's a class 2 recommendation. Those patients are taken to cath lab quickly as well. It's these patients that have no ST elevations on their EKG, but they're otherwise hemodynamically stable. So this is kind of a question is how soon do we get them to coronary angiography? Do we get them there at all? So this ended up picking, if you go to figure 1 right here, they found a total of like almost 2,500 articles to review in their meta-analysis. After duplicates, they broke it down to about 1,500. In the end, it came down to 8. So they had 1 randomized control trial. They had 7 observational studies, 6 of which were retrospective, 1 of which was a prospective study. Looking at all these things, however, because it is a meta-analysis, all these, different trials and observational studies weren't done the same way. So they had different definitions as to what early coronary angiography is. So some people defined it as early as upon admission to the hospital. Other ones defined it as up to 2 hours after admission, all the way out to between 6 and 12 hours after admission to the hospital. They looked at 4 different parameters, basically, 2 concerning mortality and 2 considering the cerebral performance scale. So this was a CPC code of 1 or 2 at discharge and 6 to 14 months out, as well as mortality at discharge and again at 6 to 14 months out. So what they said kind of, is what I thought before I even started reading the paper, that, early coronary angiography was positive across all aspects of board. Mortality at discharge, mortality out at 6 to 14 months, along with good neurological outcome based on the CPC score. So they also showed that patients taken for coronary angiography early showed a propensity. More of these patients ended up with PCI than not patients. So it's they talk about in the discussion of the paper that you can't base any guidelines off of this meta-analysis here because it's very low powered with the numbers that they were working with the 8 studies that included. However, it brought up very positive results regarding the early use of coronary angiography in STEMI patients without a hospital cardiac arrest. So I think it's when we're in the emergency departments, we have these patients. Sometimes we're in a fight with cardiology is what exactly to do, how to handle these patients. Should we send them right away into the cath? Should we fight for the patients? On that aspect of it, trying to get them to angiography earlier for probable or possible PCI.
We don't fight with cardiology.
Right. We'll edit that out.
So what do you guys think about this? Do you think that, personally I feel like, when you have a cardiac arrest, that's a failed stress test. You have some sort of stressor and you failed it. You're
Depends why you code, but listen, what's the line from this paper that, class 2A recommendation, people who are high risk NSTEMIs belong in the cath lab, but, it's always to say, figuring out who high risk NSTEMIs are is a very challenging thing. Mm-hmm. How do you know who high risk NSTEMI is? I don't know. I don't know if this article said, and maybe I missed it, but there was a great review from some interventional group, and they said that in all comers in their center, 30% of people who have NSTEMIs post-ROSC have a culprit lesion. 30%. So 30% to that means take everybody to the cath lab. 30% to the community hospital may mean I can't come in all night long, every single night, for a 30% culprit lesion, but I can come in the next morning and do it.
I've asked 2 community hospitals, interventionalists, if they would take NSTEMIs or cardiac arrest that did not show a STEMI to the cath lab, and they were like, "We'd be doing it all the time then."
Right.
And that was the thing. It was like, we don't have enough backup to be able to do that in the community hospital.
And is there really anything wrong with doing it the next day if you risk a 30% culprit lesion? I guess it could mean that you're having a greater area of infarction. But again, 70% won't have a culprit lesion, and they code it for some other reason. I don't think it's an easy answer.
Oh, it's definitely not easy. The other side to think about is for these cardiologists who are doing their interventions, now they're gonna have a lot more negative studies, and you have a certain over triage, under triage that they have to meet for accreditation and things like that. At an academic center where you have fellows, you have more people to do these, and you expect the over triage rate to be a little bit higher. And I think in Kentucky, the EMS physicians out there are working on a study right now where they convinced both their cath centers that any cardiac arrest goes straight to the cath lab, even if they had ROSC and went back into cardiac arrest with a mechanical device on, and they go straight to the cath lab.
Yeah, and so I know this is a meta-analysis, but it's 8 studies, and to me this is the best thing I've ever read on this topic. So to me this is evidence that helped us in the ER to say these patients should go to the cath lab. I mean, they may be hedged a little bit in their conclusion, but they did what any responsible author does, which says we need more studies on this.
Yeah. It's not enough numbers.
When you guys trained, what happened don't say where you trained, but when you guys trained, did they bring these patients to the cath lab? Josh?
Most no.
No?
So at our, I feel, a certain heart hospital in a certain state, I feel like more and more they're bringing them to the cath lab if they meet the criteria, obviously of STEMI, but then if they were VFib or VTAC cardiac arrest, they're just bringing them, whether or not they have an elevated troponin or anything, they're just waiting to get them over the cath lab.
I think some of it is too is how the cath labs are evaluated, because a lot of the cardiologists are reluctant to take people who are in cardiac arrest because they still get dinged as a death in the cath lab for that, which that shouldn't really be how it's calculated, but it is how it's calculated, and so that can be a reluctance sometimes too. So it maybe just changing some of the state reporting or the way it's calculated, that doesn't count, and then we might see a bigger difference.
I'm not sure I love the idea of taking somebody in cardiac arrest to the cath lab. I know people write about this, they write their case reports, there's case series. I don't know, to me, moving a patient to the cath lab is actually, I get why you're doing it, but 30% of people will only have a culprit lesion. Now you're managing a cardiac arrest and trying to cath somebody on a table.
Yeah.
I don't know, there's something that makes me feel a little uneasy about it. I get why conceptually it's maybe a good thing, but
if there's a blockage that you can relieve, could that lead to a better resuscitation? I don't know.
Okay.
I don't think the same person who's doing the cath should run the code.
So you have somebody in a Lucas device or auto pulse or something.
And you're having someone else.
I guess
running the
that's
code.
okay.
I want to see what the evidence shows.
I don't think you can get the fluoroscopy over the patient though if they have the Lucas device on, right? I mean,
No, I thought that's one of the. I thought the company says you can.
Okay.
I'm not sure. I thought the company says
Maybe
you can.
certain
I mean, they
views or
have-
something
they
like
have
one of
different
those oblique
devices,
views
yeah.
and stuff
With,
like that.
with,
yeah.
with Lucas,
Yeah.
they make a back plate that is radiolucent now. I think it's on the Lucas 3, and it's made specifically for a patient that's going up to a cath lab that they can have this on.
Yeah.
And
And
they're,
they're.
Our problem with these devices are that people take too long to put them on, which is not the fault of the company, but that's why they don't show any benefit in the literature.
Yeah.
But there's other devices like the Zoll where it's more of a band system, and that would have no problem as well. So I don't know if there's metal in there that's
Well,
going to
behind
interfere.
it though is the machinery.
Yeah.
So
Yeah.
that would be.
So that would be a problem.
I think maybe the better patient is this person who is back and forth. They're in arrest, they're ROSC, and they're just this unstable ROSC.
Well, if that's the case, you could argue two things with that patient. One is put in, one is ECMO,
Right.
and two is a balloon pump, although we know balloon pumps are by no means perfect, and most people don't know this, but it only adds half a liter per minute, right? So a balloon pump doesn't give you that much benefit, it only gives you a tiny, tiny bit of benefit. But it's something you can do quick in the emergency department, and you can do ECMO in the emergency department if you're going in and out of ROSC and you're young, right? So you're potentially salvageable. Although the ECMO literature still hasn't, to me, it hasn't panned out to what it was promised to me. It was promised to me that more people would survive, and that's not what the science is showing. Right? Particularly France and Germany were doing pre-hospital ECMO, their numbers were not that good. Any other thoughts?
I think, there's so much good studies going out there right now with cardiac arrest. We've been doing things for so long where we haven't had good evidence, and we're slowly figuring out what's the right patients and the right therapy.
All right, so I'm going to cut it short so you guys can go study. Just important upcoming dates. So don't forget to sign up for May 22nd. May 22nd is catch the email. We need numbers to sign up. It's going to be it's the EMS week dinner. I know it seems like a long time away, but it'll be here tomorrow. And it's May 22nd, 4 p.m. to 10 p.m. at the Robert Treat Hotel in the ballroom. And we'll have like 30 speakers, so it should be pretty good. Other important dates coming up for everybody? Is that it for everybody? And then we'll do some operations afterwards?
And I'll pin a link to that sign up on the Facebook page so that people can
good.
find it. So.
Good. So join us on Facebook. Always visit our ever-improving website, www.emsfellowship.com, and our Facebook page, which is www.facebook.com/EMS Fellowship.
Yep. I'll put that in the edited video too, so you can see it.
And send us comments. We'll keep on answering them. Okay, thanks for joining us.
So real quick, did have one comment that we'll have to address, I guess next week is, has anyone witnessed abnormally high end-tidal CO2 with mechanical devices? So we studied that was to Rich Zaletsky. So we did actually talk about that last week, I think, or maybe 2 weeks ago, I can't remember now. But maybe we can look for an article about falsely elevated end-tidal CO2 and cardiac arrest, and there's certain causes and stuff like that.
And by the way,
that comes up a lot.
We can, it's easily. And we looked at a great end-tidal CO2 paper last week, right, which talked about making decisions to defibrillate based upon your end-tidal CO2 levels as opposed to what you see on the monitor. So the minute you get back an end-tidal CO2 that goes up from a low number, that's when you shock VF, right? And they had better outcomes when they decide to defibrillate based upon end-tidal CO2, higher numbers versus very low numbers. So that to me was a really interesting study. Okay, thanks. Tell me more.